Hello, friends. So, at the outset, I wish to thank Dr. Subhash Todi for having me for this talk. So, the talk that was assigned to me was the must know articles in 2021 in the specialty of perioperative, transfusion related, endocrine, and oncology. So, I've tried to cover the key articles that I felt was important in last year in these four areas. So the first study that I would be covering is the perioperative and the transfusions. So the background of this is we have this TRIC-3 trial where they have looked at the transfusion thresholds in patients who underwent cardiac surgery who were at a moderately high risk for death, and they compared restrictive versus liberal transfusion. And this study showed that restrictive transfusion was non-inferior to the liberal transfusion, and they put the transfusion threshold at 8 grams per cc. So here they looked at 838 ICU patients who stayed for more than 24 hours, and even in ICU, they showed there was no mortality difference. So this was a study from the Canada. And there was another trial which came, which is the TRIS trial. This was in intensive care population in septic shock patients, where they found that 90-day mortality, there was no difference compared between the restrictive and the liberal group. And this study came from the Scandinavian group. And this was a very interesting study which came from the Spain in 2013, where even in upper GI bleed, they showed that the restrictive transfusion in fact had lower mortality. So this is the preamble or the background for the study that we are going to discuss, that restrictive transfusion is the way to go. And that is what we have adopted in our ICU based on this TRIS trial and TRIX trial, that we kept the transfusion threshold at 7 grams, and we do not want to transfuse more than 7 grams. And this is true even in patients with cardiac surgery as well, where we put the transfusion threshold at 8. So this is the study which came in February 2021, which came in JAMA. So effect of restrictive versus liberal blood transfusion strategy on major cardiovascular events among patients with AMI, acute myocardial infarction and anemia. So this is the reality randomized controlled trial. So this study was mainly to look in patients who had an MI. So they compared restrictive versus liberal transfusion, and the hypothesis was that restrictive transfusion is non-inferior. So here they had two triggers. They compared one group of the patients who got transfusion if hemoglobin was less than 8 grams, which was restrictive, and the second group which got transfusions if the hemoglobin was less than 10 grams, which was the liberal group. So they had 342 patients in the restrictive arm and 324 in the liberal arm, and 30 days follow-up was done. So this was an open label, non-inferior randomized controlled trial. And this study was done in 35 hospitals in Spain and from the France between March 2016 to 2019. So they took 668 patients who had an acute myocardial infarction or in non-STEMI with hemoglobin of 7 to 10. So 70% of these patients had NSTEMI and 30% of them had ST elevation MI. So the primary outcome, like any other cardiovascular study that you would have seen, is to look at the major adverse cardiac events, which was a composite of all-cause death or patient who developed stroke or recurrent MI or who underwent repeat emergency percutaneous intervention or a re-procedure was done. So it was a composite of these which was taken as a primary outcome. And the non-inferior, the criteria for that was when the relative risk, when the upper confidence interval level was less than 1.25, they took it as concomitant or substantiated by non-inferior as less than 1.25 the per confidence interval. The secondary outcome, they looked at individual components of the primary outcome was taken as the secondary outcome. So in the results, the median age was 77 years and the range was 69 to 84 years. 42.2% of the patients were females. And this was the results. So 668, 342 in the restrictive group and 324 in the liberal group. So day 30 major adverse cardiac events, as you see, was 11% in restrictive and compared to 14% in liberal. And relative risk was 0.79. And here you see the upper limit of confidence interval was 1.19, which is less than 1.25, which was the criteria to say this was non-inferior. And here they looked at the individual components of these outcome, all-cause death, there was no difference, 5.6% as compared to 7.7%. Recurrent MI 2.1% compared to 3.1%. Emergency revascularization 1.5% to 1.9%. And the stroke also, there was no difference between restrictive and liberal group. And obviously, the restrictive group had less transfusion. More than one transfusion was required in 35.7 as compared to liberal group, which obviously had more than one transfusion. Almost all the patients had more than one transfusion. And when you look at the evidence of harm, so now the question is that it is non-inferior, but does it cause harm? So they looked at the evidence of harm and they found that acute lung injury was found to be more common in liberal, 2.2% as compared to 0.3 in subgroup analysis. And the risk of infection also was high in the liberal group as compared to the restrictive. So which means to say, although we say that restrictive transfusion is non-inferior, the liberal transfusion comes with its own share of harm, which is acute lung injury and risk of infection, which we cannot undermine. This was seen in the subgroup analysis. So the key strengths of the study was, this is a very important study where there is a paucity of evidence, especially in patients with acute MI or non-ST elevation MI. And this was very pertinent to the clinical outcomes, and the clinical outcomes is what was looked into the study, which is the key strength. And follow-up of the patients was nearly complete. So the conclusions of this study was restrictive versus liberal transfusion in patients with acute MI. Restrictive transfusion was non-inferior with regards to 30-day major adverse cardiac events. So it's a good study, and this is a practice-changing study which we could possibly adopt in our clinical practice. So we'll move to the second domain. I was given to talk on endocrine. So now it's the COVID time, and we can't undermine the COVID and the metabolic syndrome. So this study came in JAMA, December 2021. Metabolic syndrome. So in patients with the COVID and its outcome. So they looked at the metabolic syndrome and the risk of someone developing acute respiratory distress syndrome. So here the COVID-19, we know there is the obese patients or the patients with metabolic syndrome have increased risk of developing ARDS and death. So this was a multicentric cohort study where the data was taken from the Society of Critical Care Medicine Discovery Viral Respiratory Illness University study. So it was a large data set. Retrospective data they took, and they identified the patients who had metabolic syndrome, and they looked at the outcome. So this data was from 181 countries, 181 hospitals from 26 countries. And the study was done between 15 February 2021 to 18 February 2021. So how they define metabolic syndrome? Any patient who has more than or equal to 3 criteria. So if patient is having pre-diabetes or diabetes mellitus, obese, hypertension, and dyslipidemia, any 3 of these criteria would fulfill as someone having metabolic syndrome. So the primary outcome was to look at the hospital mortality. Secondary outcome was to look at patient who developed ARDS, ICU admission, and patient who got intubated, mechanical ventilator, and length of stay. So as you see, this is a very large study looking at 46,441 patients from a huge database constituted from several countries and many hospitals. And they found 17.5% of the patients, 506 patients had metabolic syndrome, and the control group, the final analysis was done in this group. Control group was 23,971, 82.5% of the patients were in control group. So the risk of ICU admission, if you see adjusted odds ratio, was significantly more in metabolic syndrome. If you look at the confidence interval, it was significant. And the patients who needed intubation and mechanical ventilation also was more in metabolic syndrome. It was statistically significant. And the patients who developed ARDS also was more in metabolic syndrome. And patients with mortality also was more in metabolic syndrome. And as you see, all these confidence intervals are statistically significant, which means to say any patient who has a metabolic syndrome, which is any 3 of the criteria, diabetes, obesity, hypertension, or hypercholesterolemia, stand a higher risk of ICU admission, getting intubated mechanical ventilated, and developing ARDS and mortality. So they looked at ICU, the hospital length of stay. And as we see, the hospital length of stay also was longer in metabolic syndrome as compared to the control group. That was significant. And the ICU length of stay also was more in patients with metabolic syndrome as compared to the control group. And here, interestingly, they looked at what was the risk of patients with each additional criteria for metabolic syndrome. So this was a subgroup analysis where with one criteria, as you see, the risk of developing ARDS was not significant. Only 10.4% of the patients developed ARDS. But with each additional criteria, the risk of them developing ARDS and subsequent mortality was much higher. As with two criteria, it became statistically significant. 15.3% of them with two criteria developed ARDS. And with three criteria, the proportions increased further. 19.3% of the patients developed ARDS. Means with each additional criteria, there is a sequential increase in the risk of them developing ARDS, was what was shown in this study. With four criteria, it becomes even more significant. 24.3% of the patients stand the risk of developing ARDS, and it becomes more significant. So this was a very strong signal that came from this study. And this is the pictorial representation between the metabolic syndrome and the control group difference. As you see, the risk of death, intubation, and NIV is more in metabolic syndrome as compared to the control group. So in the discussion, there was a 4% absolute mortality rate difference between metabolic syndrome and non-metabolic syndrome. And metabolic syndrome constitutes a chronic low-grade inflammatory state, especially with metabolic syndrome who have this chronic low-grade inflammatory state, predisposes them to develop ARDS and mortality. And interestingly, there is a reference to obesity paradox. So what we've understood with obesity paradox is patients who have a high BMI are at an increased risk of developing severe illness. But what has been found in the previous studies is, although these patients are at an increased risk of developing severe illness, their outcomes are much better when they compare to the non-obese patients. And that is the paradox that is available. So we aren't sure whether this paradox is applicable in COVID-19, and it is debunked in COVID-19 because this paradox doesn't seem to be exist. Because when you compare obese patients with non-obese, outcomes were bad in COVID patients. But the previous studies showed that outcomes were better in obese patients, although they tend to become more sicker when compared to non-obese patients. So that's the paradigm. And the limitations of this study was there were a lot of unmeasured confounders. Like because it was a retrospective study, we do not know whether there was a homogeneity in the care, whether patients had a good access to the ICU and hospitals, and the ICU protocols would have been very different across the countries. And the socio-economic status of the patients across 26 countries in which this data was taken would have been hugely variable and heterogeneous. And the risk of having secondary infections or concurrent bacterial infections was not factored in. So there was no data capturing of this, whether this had a role in higher mortality, and whether there was a homogeneity in the mechanical ventilation, how it was provided, whether protective lung ventilation was adopted. So this data is missing from the study, and there was selection bias and the information bias. So these are some of the limitations of the study. So all in all, it's a very good study which clearly shows that patients in COVID with metabolic syndrome, which is any three of these four criteria, stand a higher risk of developing ARDS and the mortality. So that's the message for this. So that's why the newer trials that you have seen, the remdesivir trial and even the molnupiravir MOVE trial, has put obesity as one of the risk factor for the inclusion criteria. And possibly this study re-emphasizes on obesity and metabolic syndrome as a risk factor for bad outcomes. And ARDS, the increased risk of ARDS happens with each additional metabolic syndrome criteria. So that's about the second study. Then I was given the domain of oncology. So this was a very interesting study, I thought, because there's not much data. This came in Annals of Intensive Care in 2021, which it came from the French group, Patterns of ICU Admissions and Outcome in Patients with Solid Malignancy over the Revolution of Cancer Treatment. So basically to see what has been the outcome of ICU patients who get admitted with cancer as a background. So the background is the oncology patients, or the treatment paradigm of oncology patients has significantly improved with immunotherapy and targeted therapy. And this, we believe, has improved prognosis, and at the same time, having improved prognosis, these targeted therapies has also increased the toxic complications in these patients. So this study was to capture all this information to see whether the outcomes have changed between 2 decades. So that was the whole aim of this study. So this was a retrospective single center study done over 12 years between 2007 to 18. So it captures 2 decades. where they looked at unplanned ICU admissions and the outcomes. So here they have stratified the ICU admissions as specific to oncology or non-specific to oncology, or ICU admissions secondary to complications due to the drugs that they receive or to the interventions they undergo. So they took 1,525 patients, and predominantly the type of malignancies that were captured were lung cancers and the GI malignancies. These were the two important malignancies that was captured in the study. So the background of this is anti-tumor immunosurveillance has significantly increased, and that's why the risk of onco cases have significantly increased. And this has led to targeted actionable oncogenic mutations. So basically, so there are therapies which are targeted therapy or immunotherapy targeting the mutations that tend to happen in these oncology patients. And it has been shown that solid organ tumors constitutes 1/7 of critically ill patients that get admitted. And 40% of these solid organ tumors that get admitted to ICU come with metastasis. And if you look at the data, ICU patients who get admitted to solid organ tumor, 8.8% of them have metastasis, only 3.3% have no metastasis. So in this particular study, they split the patient group between two decades. So 2007 to 8 is one aspect they looked at, and 2017 to 18, they looked at the spectrum of the patients. And if you see the metastatic disease has significantly increased over a decade from 48.6% to 60.2%, which was statistically, which means the number of the proportion of patients who are coming with metastasis has increased over one decade, which is significant. And the admissions due to complications of the drugs they receive or the interventions they undergo also has doubled over last decade, and that is also statistically significant. And the crude severity of illness, there has been shown, it has been shown to have no difference between the two decades. And the ICU survival of these oncology patients is around 77.4%, and this has not changed over last decade. And that is a strong signal that is coming from this study. Despite the advances in intensive care and the oncology, there has been no difference in the survival over one decade with regards to critical care outcomes. Even the 1 year survival has not shown a difference. So these are the two strong signals that have emerged from the study. Although there has been advances in intensive care and the oncology treatment, the outcomes, the ICU outcomes and the 1 year survival has not changed over one decade. So this is a very strong signal. And the independent predictors of ICU mortality, if someone comes with metastasis, their outcome is going to be bad as compared to non-metastasis, or the tumor progression despite being on therapy also is one of the important predictors of bad outcome. And this is a graphical representation about mortality being highest in the lung cancer, followed by the breast cancer, followed by the digestive cancer or digestive tract cancer. And as you see, the mortality after ICU admission is obviously expectedly very high with metastatic, followed by advanced disease compared to the localized disease. And this is also the similar trends. As you see, the highest risk of mortality after ICU discharge seems to be with the lung and with the metastatic cancer, followed by the advanced cancer. So the independent predictors of ICU mortality is specific complications, which means complications related to the malignancy or the tumor with concomitant organ failure carries a high risk of ICU mortality. And these patients, when they go on NIV or get intubated, have high mortality. And if these patients related to cancer, if they go on vasopressor support, that constitutes higher mortality. Or someone who is going on renal replacement therapy or who have a higher SOFA score stands a higher risk of having higher ICU mortality. And 1 year mortality, the risk factors are metastatic disease or complications which are specific to the cancer, or someone who have an advanced directive of foregoing life-sustaining therapy, or someone who has a tumor progression despite being on treatment carries a higher risk of 1 year mortality. So these are typical predictors of bad outcomes. So someone who has a metastatic disease, someone who is on an organ failure, someone who has a higher organ failure score, someone who is on a renal replacement therapy, or tumor progressions despite being on treatment, which means non-responsive to the therapy being given. All of these constitute the predictors of bad outcome. So in the discussion, the authors do suggest that the survival rate, the short term and 1 year, So they put it in a different way, although we have seen that survival has not improved between 2 decades and 1 year survival has not improved. So these authors put it as a positive point, saying that it is not impaired despite being increase in the risk of cancer patients getting admitted to ICU. And organ failure support, there has been no change with the time, which means to say all the newer advances in the ICU or newer advances in oncology has not curtailed the need for organ failure in these patients, and increased prevalence of metastasis is possibly due to increased proportion of the patients who are undergoing targeted therapy or immune therapy, which means to say because there has been increased proportion of patients receiving this, so there has been increased burden of these patients coming to ICU with metastasis. So, or patients with metastasis are coming more to ICU because of delay in the progression because of these advances in the therapy. And the meta-analysis from these two groups, one from France and UK, has shown there has been improved short-term prognosis, especially in patients with solid organ tumors who come to ICU. So this is the sort of the discussion that that was generated in this paper. So all in all, you can look at the positive side of it, which means to say one would expect increase in the mortality rate because the number of patients coming to ICU with metastatic oncology sort of a situation is much higher. Um, so, and uh, and the prevalence of metastasis seems to have been increasing because of all the newer advances in therapy, which is prolonging their life, and they're living much longer with metastasis. So, and the determinants of ICU outcome is extent of organ failure and the type of malignancy and the stage of malignancy and the complications associated with these malignancies, and progression of these tumor as shown to lead to worse prognosis, both short term and long term, and local proliferation of the tumor uh, or the compression because of the tumor or veno-occlusive disease due to the tumor is all associated with the bad outcome. So the limitations of this study, it's a single center study, retrospective study, and the functional status of these patients were not captured. So those are some of the limitations of the study. So all in all, the conclusions is the patients coming to ICU with advanced and metastatic cancer has increased. But what has been promising is 3/4 of these patients survive because we saw the ICU survival is around close to 75 or to 77%, which means significant proportion of these patients, despite them coming with metastasis, they are surviving ICU, and 1/3 of them uh, will be alive even at the end of 1 year. We saw around 20 to 22% becoming are alive at the end of 1 year, and and there has been good advances in the management and prognosis of solid organ tumor, at least for short-term survival, is what we can conclude from this. So all in all, so overall in last uh, in 1 decade or between 2 decades, there has been no significant change in the outcome of these patients coming to ICU with metastatic disease. And 1 year survival also has not changed much despite the advances in oncology or in ICU is what we can sort of deduce from this paper. So now moving to the fourth domain, which is the endocrine aspect. So this is a very interesting study which came in intensive care medicine in 2021 by the French group called the controlling study, which is individualized versus conventional glucose control in critically ill patients, the controlling randomized controlled trial. So this study basically looked at targeting pre-admission glycemic control versus the standard sort of a quality indicator we follow where we maintain blood sugar less than 180, whether this improves outcome. So it was a multicentric randomized double-blinded parallel randomized controlled trial. So here they use sliding scale insulin protocol to achieve the glycemic control. Primary outcome was to look at 90-day mortality. So the background is we know for sure, friends, that hyperglycemia in ICU leads to bad outcomes. So there are these two studies which said acute hyperglycemia in intensive care leads to poor clinical outcomes. And there were two landmark studies. The first landmark was from the Vandenberg trial, which is a Belgian study, where they showed, which was the first study to indicate that maintaining lower glucose levels or rigid glycemic control between 80 to 110 led to good outcome. And then after this, the nice sugar study came from the Australasian and Canadian group. We said maintaining rigid lower glycemic control may lead to adverse outcome, and they suggested maintaining blood sugar level less than 180 is more appropriate, and this is what we have put in as a quality indicator. So this French trial was to look at whether this 180 is good enough, or should we target to patients pre-admission glycemic levels that he would have been maintaining, he or she would have been maintaining. So the methods was targeting pre-admission glycemia. Here they took HbA1c as a reference and correlated with the equivalent blood sugar level as an index that the one would maintain. So this is the targeted pre-admission glycemia. So they took HbA1c of 7.4% will equal to 180 milligram per deciliter, or 4.96% equals to 111, and 8.67% is equal to 217. So they took these sort of a correlation, and they targeted the pre-admission glycemia, and they tried to keep it below 217 for the safety reasons. And hypoglycemia was defined as less than 63 milligram per deciliter. So this was a very sort of a good study where they put in a lot of effort to try to create a good sort of a study methodology. So they had 1,917 patients, 942 in the intervention. Intervention means where they targeted pre-admission glycemia, and the control group where they targeted less than 180. So they looked at 90-day survival. There was no difference between the uh, pre-admission glycemia and the control group. ICU length of stay, there was no difference. Hypoglycemia expectedly was more in intervention, although it did not achieve statistical significance, 3.9 versus 2.5. And in the subgroup analysis, what they found is in non-diabetic, 90-day mortality was higher in the intervention group, which means you try to target pre-admission glycemia. So the risk of mortality was higher in non-diabetic patients with a, as you see, the confidence interval was significant. And the mortality was also higher in surgical patients, or when in the group where they maintained rigid sort of a glycemic control with a HbA1c of 5 to 6. So, and this group also had a higher mortality. So this was in the subgroup analysis. The strengths of this trial was it was a double-blind trial, and very seldom do we see good glycemic sort of a study in critical care, and this was a good study in that sense. And baseline characteristics were well balanced, and protocol violation was kept to minimal at less than 1%, and there was a minimal loss to follow-up. Only 9 patients lost to follow-up. So these were strengths of the study. So in the discussions, so this was very interesting. So at the end of it, when you look at the median blood sugar level difference between the interventions, so although they took a lot of efforts to try to target to the pre-admission glycemic level as an intervention group, if you see the difference between the intervention and control group overall was only only by 4 milligram per deciliter. This was 135 milligram, and control group was 139. So there was only 4 milligram difference between these two. So one could argue whether that would really make a huge difference in their outcome. So this one could argue. And here they they compared with the NICE group, and they say the strength of this was they maintained better glycemic control, because in the NICE, the median glycemic control in the control group was 144 plus or minus 23. And in Vandenberg, it was much higher, 153, and they compared to the lower group. So in that way, the median glucose level in the control group was much lower. And the hypoglycemia, when they took the range of 40 to 71 milligrams, so 27.3% of them had hypoglycemia in intervention group. And when you compare to the NICE patient, they had a very high risk of hypoglycemia. 74.2% of them had hypoglycemia, and that's where it showed bad outcome in the lower. So here, this is the strength. The authors say that there was a very good glucose control maintained, and very small percentage developed hypoglycemia as compared to the previous randomized control trials. So the limitations of this study was they used, as any of these studies, one would use algorithms with the insulin sliding scale. They use CPG algorithm to control glycemia. And one could argue, had they used different algorithms, the results would have been different. And in some of the patients, they used point of care, because we know ideally we would want to do such studies with arterial blood gas glucose level, because the errors would be much lesser. So here they use point of care in many patients, and that this would have also skewed the results, and there may have been a lack of precision. And 1,300 patients, 24% of these patients were not assessed within 96 hours before randomization, and the questions were raised whether this could have made the study underpowered. So these are some of the limitations. So at the end of it, the conclusions, it was a very good, robust study, this controlling study, which said targeting pre-admission glycemia based on HbA1c as compared to standard of care, what we follow, maintaining blood sugar less than 180, there was no survival benefit. So for all the listeners, we could subscribe that we could stick to the current practice of maintaining blood sugar level less than 180, which is good enough, and not and it is not necessary that we chase the pre-admission glycemic control. And as you see, the difference was only 4 milligram per deciliter at the end of the whole study. And really, that would not really make any sense in putting a lot of energy and efforts in trying to ascertain the pre-admission glycemia and trying to target it. So we can stick to the current standard of care. So, and I will just cover this last study in 1 or 2 minutes, so without exceeding my time limit. So this was a study which came again in 2021 in intensive care. It's called the ITACTIC, the randomized controlled trial, where the aim of the study was in patients who have trauma, augmenting major hemorrhage protocols with massive transfusion. They compared two sort of two tests to see whether there was any difference. So they used the viscoelastic hemorrhagic, this one, which is the big one, and they compared with the conventional coagulation test to see if there was any difference. So viscohemostatic assay, VHA, versus conventional coagulation test, or we call it as a TEG. So this was a multicentric randomized controlled trial. Primary outcome was to look at patients who are alive at 24 hours after major trauma and who were free of massive transfusion protocol. So this was the primary outcome. Secondary outcome was to look at 28-day mortality. Basically, they took all the trauma patients and they compared viscohemostatic assay, viscoelastic hemostatic assay, which is a TEG assay, with the conventional coagulation and see if there was any difference in the primary outcome. So results, they had 396 patients, 201 patients received this viscoelastic hemostatic assay, which is a TEG assay, compared with the conventional coagulation test in 195 patients. The primary outcome was patients who are alive at 24 hours free of major massive transfusion protocol. So, and the primary outcome was very similar between these two tests, and there was no difference. 28-day mortality also, there was no difference when these two tests were detected, which means to say these two tests performed equally well, and there was no difference with regards to massive transfusion protocol, and there was no bearing on the outcome, which is the death. And they did a subgroup analysis in severe traumatic brain injury, where they looked at again patients who were alive at 24 hours without receiving massive transfusion, and that was also very similar between these two assays. And serious adverse events, there was no difference. So conclusion is, between these two tests, viscoelastic hemostatic assay and conventional coagulation test, so the major hemorrhage protocol, when it was adopted, there was no difference in the outcome. So the take-home message, the first study in patients with MI, restrictive versus liberal. So restrictive is non-inferior with regards to 30-day major adverse cardiac events, and even individual adverse events also, there was no difference. And in patients with COVID, obesity has a role to play in influencing bad outcomes, especially metabolic syndrome. Any three of these patients has diabetes, hypertension, obesity, or hypercholesterolemia, they stand a higher risk of developing ARDS and mortality. And the risk of ARDS increases with each additional metabolic syndrome criteria. And in oncology sector, what we have found is over 1 decade, there has been no difference with regards to ICU survival or 1-year survival. And ICU survival stands at around 75%, and 1-year survival stands at around 25%. Although there has been extensive advances with regards to targeted and immune therapy, patients coming to ICU has increased, and the procedure-related complications or drug-related complications has increased, and the outcomes doesn't seem to have changed. And patients who come to admissions predominantly are with extensive metastasis, which means they are living longer with metastasis. So that was the sort of a message. And this was a very good study, very extensively conducted, very robust study called the controlling study, which showed that targeting patients with pre-admission glycemia as compared to what we follow now of maintaining blood sugar less than 180, there was no difference between them. So we can stick to the current practice of maintaining blood sugar less than 180. And this was a very interesting study. If between hematologists, there's always this debate whether TEG is better, viscoelastic hemostatic assay is better, or the conventional coagulation. This study showed there was no difference in, at least with regards to trauma patients and even in patients with traumatic brain injury. So we can stick to conventional coagulation test, which most intensive cares stick to, or most hematologists subscribe to as a ways to go about. So thank you very much. So, and with this beautiful quote, to forgive is to set a prisoner free and discover that the prisoner was you. So thank you one and all.